p.m. Pacific Standard Time, and we will start our Fall Voice webinar now on time and hopefully end on time. I'm Clark Rosen from the University of California, San Francisco Voice and Swallowing Center. Thank you for joining the Fall Voice webinar. We're 1 month away from Fall Voice 2018 in Seattle, as you can probably see on the screen. And I encourage everybody to work on getting to come to Fall Voice. If you're not already registered and not have a hotel, there are extra hotel rooms available, Allison tells me. So that should be good. Hi, Maya. And so we have a great program. So let's get started right off the bat. I want to acknowledge sponsorship for tonight's webinar from InHealth Technologies, which distributes Renew Voice and Renew Gel. They are also a gold sponsor for Fall Voice, and so I encourage you to visit them and thank them for the sponsorship for tonight's webinar. Tonight's webinar is all about lifelong learning in voice and laryngology, and we're going to try to focus on things that have happened to relatively young practitioners when they left the nest, so to speak. And, you know, that people talk about the learning curve. It's really kind of, I think, more of a slope. And sometimes that slope goes up and sometimes that slope goes down. And I feel like a lot of fellows and residents that I've worked with kind of feel like they're often at, oh, yeah, I get this. And then they get out into the real world and they're like, oh, my God, I really actually don't know anything. And that's kind of what I wanted to kind of talk about and bring out as a discussion point in today's webinar. So the concept or premise of that I hope to kind of pull out is what happens when we leave the quote unquote ivory tower / nest and start taking care of patients by ourselves, no more safety net. And what can we learn from other people's experiences as they've transitioned from student to clinician. And then if we have time, we'll also kind of talk a little bit about maybe based on what we've learned tonight about how we can maybe improve our training program so the transition from student to clinician goes a little bit smoother. That's always kind of our goal in life. One of our goals is to kind of how we can be better educators. And so hopefully we'll learn some things from tonight's panelists. We have 3 great panelists who are David Rosso, is a laryngologist at the University of Miami, Jonathan Langenstein at Northwestern University, and then Rebecca Howell from the University of Cincinnati. So I'd like to thank them for their willingness to talk about their experience as they move from the training environment to the real world. And then I've got 2 senior advisors, Milan Amin from NYU and Maya Braden from the University of Wisconsin, both who are seasoned, experienced clinicians and then also have lots of experience training individuals. And then myself as the moderator, and then Daniel Cates is going to be taking questions and screening things, so hopefully we can get a lot of people's questions as well. So again, what our format tonight will be, we're going to have each one of our panelists discuss a case / an area that they've struggled with when they were initially starting practice. Hopefully we'll get some input from our senior advisors about that specific subject matter or topic, and then maybe we'll even talk about kind of how we can improve our education programs in the future. We definitely want to hear from people who are logged into the webinar. So please, if you have a question, if we say something that doesn't make sense, if we use an abbreviation or a terminology that you need clarification, please feel free to send a question in, and we'll do everything I can to cover your questions if at all possible. So without further ado, I think we'll turn it over to David, and David's going to talk to us about his experience transitioning to from a fellow to an assistant professor and kind of his early clinical experience. So David, do you want to take over the screen?
Sure, I think I can do that. Okay. see if that works. Okay. All right, is everyone seeing that?
Yep, perfect.
Okay, great. Thanks, Clark, for having me and for that intro. I'm Dave Rosso from the University of Miami. And so this is just going to be sort of a brief discussion of really the broader concept of learning technical and procedural skills after fellowship. In particular, I'm going to talk today about my experience with learning how to do Botox injections for spasmodic dysphonia. I just want to start with a disclaimer in case anyone who knows my advisors is watching this. This is not meant to impugn the very good training that I got at the MGH Voice Center many years ago, but I think that this is more a recognition of the challenges that recent fellowship graduates face transitioning from, as Clark said, from student to independent practice. So we all know that office-based laryngeal procedures are a critical component of any laryngology practice, and it's really a staple of most fellowships these days, both in the observation and the training. Some of these procedures are definitely easier to teach. These are procedures that have a higher margin of error, are generally blessed with good visualization, so that the advisor can sort of see what the advisee is doing, and a longer procedure that allows partial involvement. So, this runs the gamut from flexible laryngoscopic biopsies to flexible laser procedures, as well as operative microlaryngoscopy procedures. There are other procedures that are much more difficult to teach, and these are ones that have smaller margin of error. Patient expectations may be very high. The procedure itself may be somewhat short, and there may be little to no visualization at all of the procedure. And with regard to the latter subject, Botox injections, I think, sort of fit into that category. Obviously, they are commonly performed in laryngology practices for a variety of indications, including spasmodic dysphonia. And many SD patients have been having these injections at the same site, or at least bouncing back and forth between sites, for many years or even decades. And these are some of the savviest patients out there. They know their disease process. They have a sort of a tight-knit community, and they know that they're looking for someone who knows what they're doing. They may not want a trainee performing their procedure. And that can be a challenge both in the ability to teach the procedure as well as the ability for the recent trainee to actually get experience doing the procedure. So most Botox injections in the US are currently performed with EMG guidance and without visualization. And this is actually, these are data from a study that USC pioneered and I was on. That manuscript is currently under review. In large part, the procedure is done through feel, and it's very difficult to teach that without direct experience. This picture here is sort of the typical picture that we all see of piercing the cricothyroid membrane and injecting the thyroretinoid muscle, and then using the EMG guidance to know when you're in the right place. And that all sounds good, but that actual process of finding that space and knowing exactly where to find the vocal fold is actually quite different. The vocal fold may not actually be above you in a superior plane. It may actually be lower. And everyone's anatomy is different. And finding those anatomic differences is part of learning how to do this. So there are expectations in performing these procedures. Recent trainees obviously are going to establish either new practices or they're going to enter existing ones. And we have to accelerate our comfort with these procedures. And you may have to compete with or even take over for an expert, which was pretty much my experience coming to the University of Miami, and I'll explain that in a second. So there are two different pathways that we can follow. Either starting a new practice and building this patient volume, where there are fewer expectations, fewer patients, and you can learn slowly, or starting with a pre-existing patient population that already is being injected by someone and they have higher expectations, there are more patients, and you need to learn on the fly. Or perhaps you can have a hybrid of those two pathways. So let me see if this video works. This is what I had to live up to when I started with Roy Cassiano, who has been doing Botox injections for over 20 years at University of Miami when I started. And he had a great deal of facility and still does have a great deal of facility with this injection.
is usually a
and can do it in 20 seconds.
Ready? 1, 2, 3. Ouch! Okay, so let's go to the left side first. I'm just feeling with my index finger the quiet just rolling it and staying to the left of the midline and advancing the needle. And you say, hee, hee, hee. That's 1.
It was 30 seconds.
And then you do the same thing, roll it over.
You're doing great, Madison.
Hee.
Right. So that took 30 seconds. That was a patient who I had tried to inject twice when I first started and failed both times. And so he went back to injecting her. And, the total number of these injections that I did as a fellow was 0. So as you can see from watching that procedure, there's not much that you can observe and learn from. You can kind of watch the motions of the hand, but until you've felt it, it's very different. It's a very different experience. So starting at Miami, this is what my first clinics looked like. I sort of walked in and there are 12 patients on the schedule. They're all savvy patients who've all been injected before. And I had to do, one of them every 5 minutes. And, just in all honesty, that was not a recipe for success. There were a lot of suboptimal injections, we can say. Some of my patients were very patient with me. In those first 2 years, I had what I used to call Botox failure clinics, which I would have to sort of bring people back who weren't injected well. And others weren't patient with me. And they said, why can't I just go back and see Dr. Cassiano again? Why isn't he doing laryngology anymore? So that is a difficult situation for a recent trainee to face. And so I think maybe at this point, before I start talking about any possible solutions, Clark, should we kick this over to the moderators?
Yeah, definitely. I have some thoughts, but I want to hear from Millen first. So, Millen, let me start you off with, well, first of all, David, let me say that I think that it's great that you brought this up. And I always have said over the years that Botox injections are the hardest things to share, to give the fellows a good experience with, because of all the situations you just said. They have high expectations, and in no uncertain terms do our patients know whose hands on the syringe. And so there's a very difficult procedure to guide somebody through or share or not have full disclosure of exactly who's doing what. And so I don't think I don't think it's an anomaly at all that you finished your fellowship from a great training place and hadn't done any Botox injections. I think that's not that uncommon across the country if you were to survey fellowship participants and program directors. So Millen, tell me what you think about this topic and how you address this in your training program, and also how would you, if David was one of your former fellows, what would you and he called you up after a couple of months of these struggles, how would you guide him?
Yeah, well, I mean, so just to step back a little bit, I mean, I think that, as you mentioned, I think this is probably the prototypical example of what we talk about when you sort of go out and practice and don't really, haven't really had the hands-on aspect of it. I will say that, a lot of this probably has a lot to do with how you sort of present the situation. So I'm actually kind of curious, David, when you went to Miami, how did Dr. Cassiano sort of handle the situation? What was the sort of build up to your showing up and taking over these Botox patients? I think that's probably a large part of this. And it sounds like it was a pretty decent handoff, but I was just curious as to how that went.
Right. It was a good handoff. There was a very clear, he was telling patients well in advance that I would be coming, and obviously every situation is different. In my particular situation, he wanted to focus exclusively on rhinology and no longer do laryngology. So he was pretty much stepping entirely away from it. So the expectation was that, there would be a transition period where, I would sort of watch him do a couple of his Botox clinics, and then pretty much I would take over.
So you were physically there, met the patients ahead of time, and he would sort of introduce you. And I mean, I think that's an ideal way to do it. Is that how it was done?
I wouldn't say I met all of the patients, but yeah, I definitely did that for, maybe 2 or 3 of those clinics.
Yeah. So I think that's important. I think, in going into a situation like that, it's very important to have mentors that are supportive in that regard, because otherwise it could obviously be a pretty, negative situation for not only the patients, but to you. It's tough. So Clark, you'd asked the question of, what do you do and what do I do in my fellowship program, or how does this sort of work? I think
what advice would you give to a 2-month out, fellow who's struggling? And I think I'd love to hear what your pearls are, especially for the young laryngologists listening on. I know David has figured it out now, and David has some of his things too, but I wanted to pick your brain, and I also wanted to open it up to Rebecca too and see about her experience.
Yeah. So, I think that, what's really important in this situation is to have a bit of humility with the situation. And I think, David, you demonstrate that. The last thing you really want to do is to go in there and blame something else, blame the patient, blame, the nurse for not drawing it up properly. And it's easy to do because you're in a situation where, the patient's staring at you or is upset by the fact that the Botox didn't go the way it always goes. And it's easy to deflect that. And I think it is important to at least take some of that on, and it gets buy-in from the patient to understand the level of skill it takes to do this. And the fact that Dr. Cassiano has been doing it for this many years, there's some value in that, and that, the patients participate in their own care in that regard. So to digress a little bit, I have a junior partner that started a year and a half ago. Well, I guess it would be in about 2 years now ago, who also trained at the same place. And he, again, did not have any hands-on Botox experience. And certainly, when he had his first Botox experience, he kind of had the same issue. He came to me and he's like, I've not done this actually physically before. Would you mind being around, if I can't do this or if something else happens? And I thought that was a very sort of wise thing to do, to lean on people who are around who can mentor you through a situation like this. And in the end, I think that the first injection, he was not able to get, and then or it was a bit of a struggle, and I just helped him with the second injection. And then the next time around, that patient came back and he was able to get the injection. So I think part of that is having, some senior mentorship around, or somebody who's going to help to support you through that. As far as when you actually go through the training aspect of it, and we can talk a little bit about this as we go further into this, but there's, options of doing some simulation type stuff. When I was a fellow, we all stuck each other, which, maybe you can't do anymore, but I certainly got stuck a few times in my neck, and Dr. Postma, I'm sure, appreciates that I stuck him a few times as well. I was somewhat fortunate in the fellowship that I did that Jamie ran essentially 2 rooms and had a huge volume and would just go back and forth. I would man one room and he would man the other, and we would just go back and forth. And there was a period of time in which Jamie threw out her back and was not available to do Botox, and I got a ton of experience that way. But clearly that's not the norm, I think, in today's fellowship programs. And so I think it's just a matter of spending time and maybe doing some simulations, again, practicing on each other and taking some advice from some senior folks.
So Milan, how about the last couple of minutes? What are your pearls and pitfalls to try to, like, if a patient comes back to you and you've had a miss, doesn't matter who did it, what do you think about that led to that miss, and what do you try to do differently?
Well, first of all, I couch it with the data that would demonstrate that, we're not 100% accurate. Even in the best of hands, we're probably about 92, 93% accurate. And so I will always say that even when I'm doing the injections or starting the injections, that look, every Botox injection is going to be different. There are times in which I'm going to miss. And if that's the case, we'll have you just come back and we'll do it again. So I think, couching it in that is important, and patients need to understand that there's not perfection. And, in David's case, for that same reason, Dr. Cassiano has been doing this for 20 years. It's just, he's got a skill in this.
Any other anatomic or specific technique pearls?
No, I mean, again, palpating the joint, going a little bit, a few millimeters lateral to the midline, or palpating the cricothyroid membrane, going a few millimeters lateral to the midline and going superior, just like it's described and shown on the diagram. I don't bend the needles, but some people do.
Yeah, yeah. Rebecca, real briefly, tell me what your experience was when you started doing these injections by yourself.
So I didn't come into a large volume. I have two partners here at Cincinnati that also do Botox clinics. So more of my experience was whoever you find is your new patient. And so in some ways, it's actually easier because they don't necessarily know. They don't have an expert, so to speak.
Yeah.
But on the other hand, they're very savvy. They're very savvy. They catch on very quickly. Some of them are just, I think a little bit more difficult and certainly leaning in and really asking for help when you don't know exactly. So I've been getting more oromotor dystonias, and then a couple that are not just a straightforward AD or AB ductor. I think one of my very first patients was actually an AB ductor, which I definitely had never done in fellowship. And so I remember phoning a friend called Dr. Belamowicz from my residency training because he has more experience than I had in fellowship, and asked him, okay, how else do I do this?
Sure. Sounds like you had the preferred route that David outlined. Just to keep moving, David, you want to tell us kind of, what you learned over time and some of your thoughts, just wrapping up?
Sure. The next slide, of course, was more just some thoughts on how best to learn, like some ideas that other people could take away, whether that's, using simulation, cadaver. I think actually one of the things that, Cassiano told me, which is helpful, is that he felt that he got comfortable doing this by doing injection augmentation procedures via the cricothyroid membrane. And so he felt that he had sort of a greater degree of comfort, whereas in my fellowship, I was trained to do them transorally, and it wasn't until later that I sort of forced myself to really learn both cricothyroid and thyroid techniques. I think probably the best idea would have been to have maybe, like with a few patients, used endoscopic guidance with EMG at the beginning, and maybe that could have been sort of a way of like training wheels almost. It just wasn't really possible with a clinic of 12 people. You can't have a scope on every single one of them.
Yeah. One thing that I think that is hard to train is what's a good EMG signal for the Botox injection and what's not. And I wonder if there is a role for us to, have, some perceptual analysis training modules, if you will, to kind of show you like this, when you get this signal, take it. If you get this signal, keep, it's like, my old medical assistant, go fish, like this is not your spot, keep looking. And, you want to, the longer the needle's in, the more the patient's getting anxious. I think that my bar for accepting a good EMG signal gets lower and lower. And I think that's sometimes where I feel like I make a mistake, or I'm like, I should have given the patient a break, whatever it is. But I wonder if we could improve this by having, it's not hard, put together, a slide deck or so of some video and audio EMG signals, kind of as good, robust EMG signals versus less than optional, less than perfect. I don't know. So I want to make sure that we have time. So Daniel, do we have questions from the audience that are pertinent to this topic?
Yes. Yeah, we do. Let's see. Here's a question about dosing. If a patient comes to see you and they had been followed by a previous practitioner doing the Botox injections, and they say that, I have always received dose X, do you try to keep them at their usual, quote unquote, usual dose that they have been accustomed to, or do you kind of start over, hit the reset button, and do something that perhaps maybe you're more comfortable with?
That is a great question. Let's go around the horn. David, what do you do? What did you do?
That is a great question. I'll try the initial dose that they started with, but I warn them that you know, X number of units in someone else's hands are very different than in my hands. And I think I have patients from Dr. Blitzer who come in and they're on these tiny, tiny doses of like 0.06 units or something. And I'm like, I am fairly confident that I'll need a higher dose, but we'll try it.
Millen?
Yeah, no, I would echo that same comment. You know, we see patients with like, you know, 0.32 units, and I just don't know that I can, you know, equivalently inject that exact specific amount. And I will always tell them, look, you know, I can put the exact same dose, but it may go in a different area and it's going to have a different result. So, you know, 0.03 and 0.05 differences mean nothing really in that regard. We really have to just find something that works for both you and me in my hands.
Yeah, it's a really good question. I just, you know, inherited a practice, and by and large, the practice used so much more Botox dosing, higher dose Botox dosing than I was ever comfortable with, that I have this conversation every single Friday. You're used to getting X number, but that seems like a super, super high dose to me. And I'm about a 50-50 hit rate where like, people, you know, I want the same dose. You know, as long as they're like aware. And then other people I've been talking, try it down just because I feel like it's different. It's really a difficult issue. And I think that the most important thing that, you know, we could take home from this is what Millen said. It's about, you know, communicating, educating the patients. So they know the variability from provider to provider. And then of course there's variability from injection to injection. Daniel, do you have another one for us?
Do you think there's a role of using a neurologist or an electroneugrapher in the setting of Botox injections and interpreting the EMG?
So I definitely don't. So Millen, why don't you answer that, and then I'll chime in.
So I've been through this. You know, when I was in fellowship, Jamie always had an electromyographer there, as did Greg, and it was a nice environment because you sort of collaborated together, and it was a lot faster. When I first arrived at NYU, I established that relationship, and we didn't have a machine, so I went over there. And it was just so time consuming. So it was the opposite, because I had to go over there. We had to get there early enough, set up the patients. And if there were delays, I couldn't do any work because it was in a different location. Yeah. In the end, we ended up getting our own machine and going back to just me doing it myself. I think from a perspective of, you know, understanding the neurophysiology, it's probably better to have somebody there. But for Botox, all you're really looking for is a signal that you can inject into.
I don't think you need it long term, but it's an interesting question from a, you know, again, starting out. This is back to our theme. Would it be helpful to the person, you know, to have a seasoned neurologist that does EMG all day long? Maybe. It's an interesting question. So I think it's a good time to transition. I don't want to shorten anybody. So let's switch gears, and Jonalyn, you want to tell us a story and educate us?
Yes. Let me start to share my screen. I'm going to present to you a case that this is actually during my fellowship year, the person that I'm thinking of during my time at Emory, but I would say it was pretty much towards the end, and I think this is a case that's pretty applicable for somebody who's just starting out doing voice therapy by themselves for the most part. And so I'm going to present this patient to you. She's a 55-year-old female complaining of a scratchy voice and just not sounding like herself, periodic low-level sore throats with voice use. These symptoms all seem to worsen with voice use and improve with rest. Her symptoms started gradually about 5 years ago and are fairly stable at this point. Some other pertinent medical history includes depression and allergies. She takes Claritin as needed. In general, she has low to moderate vocal demands. She is an artist. She's married with one son who's a sophomore at Cal, originally from the Bay Area. So I will take a moment right now to just say I am originally from San Francisco. I love the Bay Area. It was a treat to see someone in my fellowship in Atlanta who is a Bay Area native. So I feel like we had a good connection right off the bat. Perceptually, her voice was not overly dysphonic. If I am thinking back, she was probably about a 1.5 on the Gribus with inconsistent roughness and some strain. Primary features to me were low airflow and kind of posterior back resonance. Laryngoscopy was with the normal limits, and then when we looked at her strobe parameters, everything was pretty much intact, but she had intermittent aperiodicity, which goes along with the low airflow theme that she had going on. So if I recall, she was not very stimulable at the time when I initially evaluated her, but she was amenable to therapy. I felt like because of this connection that we had, I was excited to start working with her in therapy. And so I recommended four sessions of therapy, which is our typical course when we first started. So jumping into kind of what we were doing in therapy. So after about several sessions in, she was really just getting emerging success with some of our techniques. We were working on overall just improving vocal efficiency. We were targeting airflow plus phonation. Some of the things that I don't remember exactly what we worked on, but I'm for sure we were working on diaphragmatic breathing, probably some semi-occluded vocal tract exercises. But carryover was really only right after the exercises, like immediately post-exercises, her voice would be a little bit better. But she was unable to carry it over beyond the exercises. And she really had low insight into this airflow concept. She was also not practicing. She would just be really honest with me, like, oh, I didn't have time to do it. And and that was just what it was through the whole course of therapy. She would commit to doing it and then she wouldn't do it. So what I ended up doing was, I'm changing the approach. We're going to work on resonance. Maybe you're going to connect a lot more with this concept. So either the same exercises or the new voice exercises, whatever I presented, but kind of just with this just different focus, because we know these things, airflow and resonance, they really beget each other. So again, low awareness into how her voice was different and why. And I kind of just recall resorting to kind of like, well, I know you don't understand these things, and I know you're not going to practice these things, so let's just talk about these general concepts of voice production, which we had been discussing all along, but at the end of the therapy, I was just kind of like, well, you are not connecting with these different concepts. After 4 sessions, maybe more, the patient felt that her symptoms were somewhat better in that she didn't have as much sore throats. Whether that was true or whether she just wanted to throw me a bone, I'm not sure. But her voice was essentially the same. I suggested more therapy, either with myself or one of my colleagues, since she declined. And as far as I know, she did not get any further therapy. So reflecting on my kind of pitfalls about the situation. So I have a pitfall slide and I have a pearl slide to redeem myself.
So John, let's go back one if you don't mind, and then let's see what Maya thinks and hear from Maya a little bit before we go to your personal reflection.
Totally.
Maya, what do you think? When you hear this story from somebody who just finished your CFY, what's your questions to your former mentee, and what's your thought process?
So I'd back up to the very beginning of therapy. And kind of that first end of your evaluation session or first therapy session if they've shown up. Because we know even showing up to the first session can sometimes be a big barrier to therapy. Kind of wondering about what was your sense at that point about what her level of motivation, buy-in to that therapy would be helpful, understanding of what was going on with her voice, all of those pieces coming together. Was there any motivational interviewing or kind of figuring out if this was really, if her goals were in line with what your goals were?
Yes, those are definitely things that I have reflected on with this case in terms of motivational interviewing, for sure. That's definitely a skill set that I have acquired over time. But I'm interested in your thoughts about how to essentially, like, how do I teach these things, or how were they, like David said, I had a great fellowship. Not all things are possible to be taught and spoon-fed in a fellowship, but now that I'm teaching students on a full-time basis, like how do I instill those things? I definitely take the time to set up my expectations in therapy, just like you were saying, like backing up to the first session. But I think it's until you're in those moments that it's hard to kind of put it all together. I'm interested in thoughts about how you teach that.
Well, another thing I would add is, sometimes it's not our fault that people don't get better. And that's a really, really hard thing as a new clinician, because, you're sort of unsure of your own skills and abilities. And, it might be that you're choosing the wrong targets and the wrong way of approaching the patient, or it could be that either they're not ready for change, or even backing up to the diagnosis. Is it a diagnosis that is compatible with voice? Is voice therapy really going to be the best first line? I think for this patient, it definitely sounds like it was, but being able to kind of reflect on that and not take it all onto ourselves. And I think that's hard anytime as a clinician, because we want to fix things. We want to help people get better. And sometimes it's not our fault that they don't. So, but I think that's a really hard thing to teach, because we also want to teach our students and our fellows to do their best and to always be reflecting on whether they are choosing the right approaches, whether they are, training the patients the right way. If we are, if we've got all of the right components and they're still not getting better, though, what's going on?
So it seems like there's two important subcomponents to this conversation. One is, how do you select somebody who you meet on their evaluation that isn't a candidate, is or isn't a candidate for therapy? So you kind of, I'm going to offer you voice therapy or not. And then while it is starting, how do you monitor your progress in those early sessions after session 1, session 2, session 3, that, okay, we need to do something different? Maya, can you weigh in on those two topics?
Right. And so my bias is almost always to offer therapy, because I think even when it's not going to be maximally successful, it's still going to help in some ways. But discussing with the patient, if this is really, did they just come in to find out that there's nothing, that they're not dying? Or did they actually, are they really bothered by their voice and they want to make these changes? That's one of the first things. So what's their motivation for being here and for changing? But then once, I think we always have to be assessing online, with every single thing that we say and we do. Did that move us in the right direction? Did they understand us? Do we need to find a different way of presenting this? So it's really a constant ongoing process throughout every session, reflecting back at the end of a session, thinking ahead to the next session. Is what we're doing working? Is there something we need to change? And if things change with the patient too.
Agreed.
Any other thoughts?
I actually have a question, if we have a down minute, which is that, when you're in a CFY, you're in a certain environment and you're used to that sort of play with the physician who's there, with the senior speech language pathologists that are there, the other team members. And then what happens when you go off to an environment which is very, very different? You have to relearn and you have to adapt to that situation. How you have any suggestions on how people do that, or what's the best way to sort of think about that?
I feel like I'm currently in I am in a new setting as of about a year ago, and that has it's there. I'm the only voice therapist on the team, and so I feel like a lot of times I feel fairly comfortable with what's going on, but I certainly don't have the same collegiality in terms of other speech pathologists that I can bounce ideas off. Fortunately, you make friends everywhere you go. So I am reaching out to former mentors and other speech pathology friends and bouncing ideas off of each other. I mean, we all belong to the SIG3, and people are constantly posting questions or the voice serve. I think that's a really appropriate way to get feedback. Continuing education, I think that's another great way.
What about relationships with the physicians, like the laryngologists, or other things? I mean, that's a completely different environment if you go from one to the other, and how people interact, or how you interact specifically with that person. Maybe you can tell a little bit about that experience too.
I think my personality and the tendency of a lot of speech pathologists is to kind of go with the flow and assess the situation. You make friends and play nice. As an outsider coming into that situation, I don't want to come in and upset the fruit basket too much about how things are run or how my ideas that I come in. But I think as you show your colleagues, your training and your ideas and how your ideas might have value too, as they get more comfortable with you, they might be able to be more open-minded to some of your ideas, and I can be open-minded to theirs too, because just because it's the way I always did it doesn't mean that it's the way that it's going to happen. So we adapt. Maya, do you have any thoughts?
Yeah, so I similar thoughts. And our voice world is so small, and there's a lot of cross-pollination. So I think, there are similar models and there are similar approaches across different voice clinics, and I've worked in 3. And then right now I work with several different physicians, and I work with several different speech pathologists, and everybody has their own different approaches and training. But I think kind of mutual respect is really important, and remembering that everybody's bringing something a little bit different to the table. We might have different experiences, but those experiences then, we can learn how to work together, and we can sort of build different teams and different partnerships, kind of depending on where we are, depending on who's there, what patient population we're seeing, training, and things we learn along the way as everybody, I hope all of us constantly are learning more and more past our fellowships and trainings. And
Absolutely. Daniel, do you have any questions before we leave this topic and move to our last?
Yes. If a patient is not making any progress, but the patient insists on having more and more voice therapy sessions, do you have a great way for cutting the cord?
Maya?
I have a couple answers. Do you mind if I answer?
Yeah,
a couple
I would
answers.
love it.
One is actually talking about what their end goals are, and why they think they're not there and why they want more. I also work with a lot of children, and so sometimes the parents want more therapy and the kids do not, and we sometimes have to talk about what's a realistic endpoint right now for kids, and different from what the parents want. What about you, Jolyn?
I would say the same thing. I would also, I take it back to kind of the stroboscopy. I take it back to physiologically what's going on, their awareness building, my expectations for change. And I now try and set that right off the bat, so that the way people are not surprised 4 sessions in, we try and kind of prepare them for this is going to come to an end at some point, and eventually that plug needs to get pulled.
Yeah.
They're not your permanent speech pathologist.
Yeah.
Yeah, we're not doing this every Tuesday at 10 o'clock for the rest of your life.
Right.
Daniel, do you have another one?
Yeah. Do you have any advice for new laryngologists starting out who are sending patients for voice evaluation, voice therapy? In other words, is there a way that we can start the process to make their first session more successful?
It's a great
That's a great
Go ahead,
question.
Maya.
I would say so. Yes, and I think this is actually backed up with some studies too. But the buy-in is really important. So if you express confidence in the speech pathologist that you're working with, that already sets the stage for the patient to have confidence in it. And
then Maya, can I just chime in? It's not only confidence in the speech pathologist, but it's the confidence in the fact that voice therapy will help them.
Right. Exactly. Yeah. Confidence that. Yeah.
Anything else?
Setting out expectations realistically too. So the confidence that speech therapy, voice therapy will help, but also if there are reasons that it may have limitations, to be honest about those too.
Right.
Well, the other thing I would say is that you always have to, preface it by, this is not just going there and then having them do something to you. It's that you're actively participating in this. And if you're not going to do that, then it's not going to work.
Right.
So
I say the exact same thing, Millen, again and again every day, that this isn't a 15-minute treatment session like you came in and get a massage or, get physical therapy, applied heat to your back muscle, and then you get better. This is you learning from your speech language pathologist and then you applying it every single day until you see them next week and get it integrated into your, into your everyday use. And if you don't ever successfully do that, you're not going to get better. All right, I don't want to shortchange Rebecca. This was a great topic. We could talk about this more, and maybe we will with future webinars. So, Rebecca, do you want to take over and tell us a story?
Yes. All right. Can you see my screen?
No.
Not yet.
Okay. Sorry. How about now?
Yes.
Yes? Good? Okay.
All 10 screens.
Great. Oh gosh, I hope you're just seeing this one. Are you seeing just the pictures?
Mm-hmm.
Yes.
Okay. All right. Well, thank you. Thank you for allowing me to be a part of this. This is a fun panel. When Dr. Rosen first asked me to be a part of this, he asked, do I have ideas for early career learning? And I'll first admit that I have lots of ideas, some good, some bad, and some ugly. And I think that continuing on the Botox theme, we sort of agreed to try to discuss actually cricopharyngeal dysfunction and the utilization of Botox. So this also goes in line, it comes in line with the Fall Voice webinar last week for anybody who joined in for that. Ashley and Kate gave a great webinar on HRM. And I think HRM is going to be one of those tools and diagnostic instruments that I think is going to help with both diagnostic and therapeutic, which is going to help so that I don't make the same mistakes twice. So again, my name is Dr. Rebecca Howe. I'm from the University of Cincinnati, and we're going to talk about cricopharyngeal dysfunction and lifelong learning and dysphagia algorithms. So not important to belabor this. The proximal esophageal segment and the cricopharyngeus muscle is sort of where we're headed here. And in a very shameless plug, I am also the PI for a large multi-institutional study, which Dr. Postma very kindly calls the Big Zinc study, but it's technically called the cricopharyngeal dysfunction and esophageal diverticulum prospective study. We now have 51 patients enrolled. We're looking for 300. We have 10 sites enrolled. So this is very exciting. This was a project that was thanks to Dr. Murati, Dr. Postma, Dr. Bolofsky, and Dr. Pittman, and all of their inputs into what causes the Zankers so that we could actually pull out the information, and also what causes cricopharyngeal dysfunction. And it was Dr. Pittman that really wanted to include cricopharyngeal dysfunction. We agreed to keep it in as an early, as it applies to an early Zankers. And the reason that we tried to limit it is because I think the cricopharyngeal dysfunction is not a one size fits all. In fact, I don't even think it's a one size fits most. So on to our case study. So this is a 74-year-old female who I took care of with progressive dysphagia. When history is always very important in these patients. So back in 2000, she had a squame of her palate. She was treated with transoral resection and radiation. She was subsequently lost to follow-up, as many of our cancer survivors are, and shows up again in 2011. Her evaluation with my speech pathology colleagues noted some mild oropharyngeal dysphagia, again characterized by xerostomia, weakness of the base of tongue, poor excursion, all secondary to radiation fibrosis. So in 2017, she shows up again. Now she presents with maintaining her diet, but now she's actually altered what her intake is because she's choking on all consistencies. So purees, liquids, and solids. I always ask if there's a particular, I think in my mind, there is a difference between solids, liquids, and purees. She was having problems with all of them. Important as well is that she does deny nasal regurgitation. Given her history of a palatal resection, this is important because this is one of those ports. Again, one of those important ports that I think we will learn a lot more about and exactly what it is that it's doing for us from a pressurization of the swallow. So again, I have my speech pathologists to thank. I work with phenomenal speech pathologists, Bernice Klaben, Courtney Robinson, Farah Kaval, Aaron Broderick, Heather Webster. They are phenomenal, and I have learned so much. So they did the heavy work in educating the patient, really telling her, again, this is a long-term problem. This does not go away. You can't, as Dr. Rosen said, put a heating pad on your back and be done with it. This is something that you're going to have to really work for. So started her on Shakir, Masako, myofascial, started her on exercises, and also ordered an MBS. So they ordered her MBS. And with her MBS findings, not surprising again, she has, residue in the vallecula, she's got residue in the pharynx, multiple swallows still do not clear her pharyngeal residue. What you also see is a cricopharyngeal bar, so a prominent bar, as well as a very small web, which I think you could probably see a little bit better on the still picture previously. So she agreed to the evaluation, and so she came to see me, and I said, well, sure, you have a cricopharyngeal bar, and again, like Dr. O'Rourke talked about last week, and Dr. Postma had so kindly taught me, usually we use the 50% rule, so you have a 50% radiographic obstruction, you would be a reasonable candidate. Now, one thing that I have, I opt for Botox instead of going to a cricopharyngeal myotomy, because I've had some of these failures. And thankfully, and I warn patients ahead of time that this is, the good and the bad is that Botox is temporary. And so if it works for you, that's unfortunate because we will have to do a second surgery, whether it's another Botox or it's a myotomy. But on the other hand, if it's not working or if it's not what you want, it's going to go away. We just have to give it some time. And then, so we went in, we did a CP Botox. I did a dilation at the same time. Everything went very smoothly. As Botox, the normal onset of Botox, 2 to 3 days, the phone calls started. And the phone calls kept coming every day about how her swallowing was so much worse than it was before. And now she's aspirating on everything. She's choking on everything. There's no consistency to food. It won't go down. And she's a public speaker as well. And so one of her big complaints was that she was belching. So she was belching uncontrollably in public. And so she refused to come into the office, but she agreed to have a repeat modified swallow. So again, you'll see the pharyngeal weakness. She still has the residue, but now she is frankly aspirating. She doesn't have a CP bar. So the bar is gone, the obstruction is gone, but because she's still got so much pharyngeal weakness, she is actually, as compared to before where she was penetrating, now she's frankly aspirating. So she agreed to go back to my colleagues in speech, and she was, again, for whatever reason, pancakes and Brussels sprouts were okay. So she was on a diet of pancakes and Brussels sprouts for several months. So I'm happy to say that now, more than 6 months later, she is actually very happy. She's very happy, even though the Botox would have worn off by now. But her swallow is better than it's been. So better than before, improved all around. But is it because maybe I just dilated the web? Is it because she needed the Botox? Is it because she just needed speech pathology and really she didn't need me at all? All things possible. And I can't really tell you actually which one is which. So again, in her modifieds, just to point out, my wonderful speech pathologists, they're so kind that they actually give me a bright yellow arrow just in case I'm going to miss the aspiration there. As well as showing me these nice, showed that, again, the narrowing of the CP opening, it's open. She's got reduced retraction. She has the opening though. Again, you don't see that 50% bar anymore. So my advice, I think in the world of dysphagia, especially surgical dysphagia, I think it's a bit in its seedling phase. I think there's a lot that we need to do to make it better so that we can actually better counsel patients. What I've learned from my Botox failures is that I counsel them that, again, it can be temporary, it can be permanent, there is a permanent option if it works. And I also actually more and more have now told them, if you aren't doing well in the first week, call and we can set you up for a fees right away. I think that fees is very helpful because, again, it shows patients what's happening, what's going on, and again, gets them plugged in with my speech pathology colleagues. So I think my advice for early trainees is don't let the imposter syndrome cripple you. And to borrow from Sheryl Sandberg's book, lean in. So lean in to anyone who will stand with you, to anyone who will help you to treat tough patients. Learn from your near misses, and your disasters. To my old mentors, yes, that's you, Dr. Postma. You can always continue to be. You continue to be a soundboard, and I'm grateful for all of my, again, Steve Bellamowich as well. I'm grateful for all my former mentors. But I would say in my early years, I really have my speech pathology colleagues to thank. They've given me a different set of eyes to look at things. They have given me different ways to consider what I'm doing. And you know, I mentioned before all my swallowing colleagues, but my voice colleagues, Renee Goosen, Lauren McHale, Caitlin Reed, and Wendy LeBourne are all in my community here in Cincinnati. And I'm incredibly grateful for all of them for my development that they've helped with.
Millen, do you want to talk a little bit about Botox versus myotomy in these patients? I know the time is short, but it would be interesting to hear what you think.
Sure. I mean, obviously, this could be a whole webinar in and of itself, but I think that, you know, the experience that Rebecca had with a Botox injection for a CP bar is one that we've all encountered over the years. And I think that, you know, at least in my own view, the enthusiasm that I've had for Botox for CP bars in my early years has essentially waned. And it's much more of a rarity that I will do the Botox anymore because of this feared complication, really. I mean, it's not that it was a long-lasting issue, but a patient that you take that is eating and all of a sudden can't eat and is aspirating is not only, you know, difficult from a call perspective, they call you a lot, but it's just a feeling that you don't want to have, is that you made somebody much worse. In the end, you know, whether this patient got better because the therapy, or whether, in my view, sometimes you made them so bad that they were just happy to be back to where they were, may be the case there. But I think in general, and I've talked to many of my colleagues who do this, many of them have over the years decreased not only the amount of the quantity of Botox that they inject, but the total number of patients that they're injecting with Botox over time in favor of things like dilation and or myotomy.
Daniel, do you have a one last question we can squeeze in before we lose the hour?
Yeah. Do you have any sort of algorithm for which patients get the more conservative treatments like Botox versus jumping straight to a myotomy?
So just as Dr. Amin had suggested, my initial enthusiasm has waned because I've had a lot of these. This is just one good example. And it's not to say that you don't get some real wins too. You do. So I haven't completely nixed it from my practice, but I'm looking for a better way of managing these patients. So again, if it's an early Zenker's, it's a cripharyngeal bar with an early Zenker's. I think that it's more useful. I think a lot of it's based off of the symptomatology. I also, again, my personal bias, I think, is that if there's a neuro component, so they've had a stroke or they've had another neurological issue, I think that probably doing either a myotomy or a trial of Botox could be helpful. But again, I've gotten the opposite results too. So I will say that I will do Botox before I do a myotomy most of the time.
How about you, Millen?
Yeah, I mean, I would agree with that. You know, that I'm more prone to, if I'm going to do something quote unquote conservative, I may consider a dilation, although, you know, I will tell them that it's not going to be nearly as effective as something like a myotomy.
Right. Mm-hmm. All right. Well, listen, we've used up our hour. We have a lot more subject matter we can cover, but we do have future webinars, as well as we have Fall Voice in a month. So I'd like to thank everybody for participating. I want to remind everybody that we have a lot of great stuff coming in 1 month in Seattle. So I hope to see everybody there. And thanks again for tuning in, and stay tuned in for Fall Voice 2018 in Seattle. Thank you very much, and have a good night.